Welcome to Cardiac Surgery Simplified, a series where we discuss interesting cases and highlight key moments during surgical procedures. Presented by the Frankel Cardiovascular Center.
Today, we present a 71-year-old male with NYHA Class 1 symptoms. He presented with posterior prolapse with flail in the setting of moderate posterior MAC and also had severe MR. He elected to undergo a minimally invasive mitral valve repair through a right mini thoracotomy with groin cannulation. The approach to mitral valve repair in this video includes a detachment of the posterior leaflet, followed by ultrasonic removal of leaflet calcification and MAC. We then reattach the posterior leaflet to the annulus, place an annuloplasty band, and conclude the procedure with a chordal repair. His preoperative CT demonstrated moderate but dense posterior calcification. His preoperative echo demonstrated posterior MAC that involves the leaflet. His 3D echo demonstrated P2 and chordal flail, as well as posterior MAC. Annular sutures have been placed for exposure, along with 3 neocords in the papillary muscles. The highlighted area reveals calcification of the posterior annulus involving the posterior leaflet. By probing the annulus, we can assess its rigidity and the extent of calcification. We detach where the annular calcification is at the base of the leaflet. This will prepare the annulus and leaflet for ultrasonic aspiration, which will improve the mobility of the leaflet. Once the posterior leaflet is detached, ultrasonic debridement is used to carefully remove the calcium deposits from the posterior leaflet. This allows us to remove calcium that is restricting leaflet movement and will help ensure better coaptation and reduction of calcification progression. We sharply remove calcified portions of the leaflet and affected cords. We now focus on removing calcium along the annulus. This is especially important for preserving valve integrity and for allowing reattachment of the posterior leaflet to the annulus. After ultrasonic aspiration, calcium fragments are irrigated and cleaned from the annulus. The posterior leaflet is then reattached using running 4-0 PTFE sutures in 2 layers. After reattaching the posterior leaflet to the annulus, we now perform our traditional chordal repair. We utilize 5mm endoclips to temporarily set the height of the cords. Valve testing here shows normal mobility of the posterior leaflet with a correction of P2 prolapse. There is a residual jet from a cleft between P1 and P2. We size to a 40mm band. After securing the band, the valve is retested, still demonstrating the residual jet from P1, P2. We mark this prolapsing segment in preparation for an additional neocord. An additional pleated neocord is then placed at the medial papillary muscle. We utilize pledgets to minimize trauma to the muscle. We place 6 gentle knots to ensure that if one cord breaks in the future, the other will still function. We then insert the neocord into the posterior leaflet. We can set the height of the neocord as needed by placing a new endoclip to optimize valve coaptation. There is a residual leak at P1 and P2, which we will close. We plicate the cleft at P1, P2 using a 4-0 ethobond. Final testing shows that there is no longer residual mitral regurgitation. His post-operative echo demonstrates good valve and ventricular function, as well as normal mobility of the posterior leaflet. There is no residual mitral regurgitation, and the valve now has good coaptation. We presented a 71-year-old male who underwent minimally invasive mitral valve repair for posterior prolapse with MAC. The case summary includes debridement of posterior MAC with reattachment of the posterior leaflet to the posterior annulus, as well as the placement of an annuloplasty band and chordal repair.